Can you hear me, Janet?
Yes.
Oh, why are you? Say it again? Can you hear me?
Yeah.
Huh. So, say it again?
Can you hear me?
Yeah, that's way better. Okay.
Okay.
Cool. Thank you.
Yep.
And then last thing is, can you see the slides?
Yeah.
Sweet. Thank you.
Yep.
Sure.
Then you guys. Oh. You mean I have to read as well? Probably the second time I was skiing was at Bogus. And I'm just close. Hey, oh, morning, morning. Just kind of close. So I get on the chair. It starts going up. And I lose the speed. So that one ski out. And my wife, I think, was in the chair I held, and she noticed it. So as we're kind of getting the point, we're trying to get off of it. The operator says, just hop. And I'm saying, if I'm able to hop on ski, I should never have lost a ski in the first place. I'm good enough to literally hop on the ski, get away from the chair, look at the little tiny downhill area. Say right top, so I was like right here taking the picture. Yeah. Actually, right. Go ahead. So this is what you. Yeah, no, that's definitely. Well, I hope they wrapped it, shows it, but. If you go ahead, if they ever call you, I said, is there? What's that? The pen working? Yeah. Yeah, this is new. I'm gonna use save my usual spot here. Have a good one. All right. Good morning.
I was all ready to come last week, all packed up, ready to walk.
Oh, dude, you can't lock in on me, man.
And then Paige was like, you didn't see the email? My fuck email.
Dude, you gotta go check the email.
I barely saw it too.
Ashley, she's like their liaison over there. And she like calls me, the day before. And like, he got booked like a last minute surgery the day, like, that morning.
Yeah.
She called me the night before. And then we're like in the morning, and then we're like, all right, it's like, if he can give like 30 minutes, that's totally fine. So we wanted to do it. And then just like went back and forth. And then at night, like on like 6 or 7 p.m., she called me like, we can't do it. So, but it is what it is.
Yeah.
Hopefully he'll do it another time. It's down.
Well, hopefully, yeah, because this year's academic, or this academic year has been filled up, but I think I can book it for next academic year, so 26, 27. So like start in September of this year. I give another talk.
Okay.
But yeah, we've been in talk.
So the last grant rounds, I still haven't been able to pull it. I have access to it,
Yeah.
but I can't download it. I don't have writable abilities.
Okay.
I don't have permission.
Check. Yeah, gave you.
It's the same with this one. When you get done recording this one, I'll need the same permission for this one. So it looks like we'll have to do it for every video, unless you drag this one and the last one into where you saved them before, because I can move them from there. There's nothing there right now.
Yeah, I just leave them on the file. Like I never do anything. All I ever do is like after we're done with this, save reports.
Well, I know, but they're sitting in the meeting spot instead of the saved drive.
Got it.
If you move them to the saved drive, I can pull them.
Okay.
I know, it's weird.
What's the best way for me
Okay.
I'm actually giving credit, but I
Uh,
sign in and
yeah,
all
yeah.
that, but
The person who talks to you, with her name is Riley Farnham.
I.
And I can.
Okay, you want to just.
Yeah. She is out now.
Put around my content. That's good. Yeah, it doesn't, you put it for you.
And I just sent her a message, but
Is she over in the education?
No, she's like right here. Oh, yeah, yeah. Because it's all, right here's all the residency.
Right.
Here. So she, her and Jan is another person in knowledge, you know. They take care of all the SU stuff. Well, Riley really does.
I'm wondering, since I'm not on staff here.
Yeah.
Or anything else, because I had talked to them before,
Yeah.
they sort of sent me down to the education department.
Oh.
And so
Yeah. That's the extent that I know. Like, because Riley kind of like, after we're done today, I sent her the attendance sheet
Right.
and everyone that's signing in. She comes and takes care of all the seeing and stuff after that. So she's kind of the go-to person for this.
Okay. Well,
Yeah.
I'll catch up with her sometime.
Yeah,
Next few weeks.
she should be back in the.
Oh, right.
Yeah. So she,
She did a lot of sitting around on this.
like super sure, but she should bad.
Well, the person in the education, I may want to just stop over there because I think that's probably
Yeah.
the most guaranteed. 'Cause
Yeah.
when I connected with them here,
Yeah.
they said, well, I put your name in.
Yeah.
And they're done.
Yeah.
And so,
You shall see.
yeah, to be determined.
To be determined.
Thank you very much. Well,
And I can tell you, I'm moving autograph now to YouTube.
No, I didn't know that.
Yeah, I'm Boise YouTube page because we have so many docs that visit here, do their presentations, and then want a copy of everything.
Got it.
This way they can get it.
Okay. Really, that is, if they people want this, yeah.
Yeah, a lot of people want to see it. I really want to share it with their buds. What you got to do here? You're putting forward.
Oh, or, yeah. So, yeah, finished it and talked to Mary and, yeah, it's sort of got to the daughter.
When do you go off to the Midwest?
Maybe it's June, somewhere around mid-June.
Graduation time?
Well, yeah, like I'm gonna go there in April, mid-April, early April, 'cause I gotta, my family, with the.
I'm gonna say, don't you have to find a place to live in?
Yeah, dude, I did go there in like 5 days finally done.
Oh my gosh, no stress.
Yeah, so we're signing a bunch of we booked a bunch of places and then.
Are you doing like Airbnb?
Oh, you are. Get there. We booked like 2 places to go the first day to get there. And yeah, figure out like the fraction. Whole plots and. Yeah, like, here. There's very yeah. And you do it. I know when I moved here. Yeah. Oh, shit, I think ever I came to here. When when I moved to San Diego, so I got to go to Tacoma, but like it's a short bed. There's like a double tab, a short bed. I could fit everything I needed in my life, and that's Tacoma. I just go back here and go back here and go. But I didn't like I didn't have a match with anything like that. Yeah, I didn't have matches. I didn't have a TV. I didn't have like was basically like it would be very very. That's how you do it. Yeah. 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 Oh my God, dude, put down like here. And can't do it. You just have to go. Yeah. Oh, I'm back here. That's it. Yeah, see the last year or something. Yeah, a couple of these. Yeah. You're all good to go. You're all, I gotta wait for people. Ready. Oh. That's Dr. Klein. He's our nephrologist there.
And
My hands.
it's nice to meet you.
Nice.
I looked you up last night. We kind of came from similar places. Watched you for med school. You done her residency and chief here at the VA,
Okay,
Colorado, and then I've been here since 2001,
got
a long time.
it. You like mountains, it sounds.
Yeah, yeah. But nice to meet you. Yeah.
And so you're at the VA and then,
So I'm in private practice, so we contract here in Eureka. So there are 5 of us, 4 APPs,
uh,
5 nephrologists.
that's
We
great.
run over all over town, over Treasure Valley,
Wow.
Eastern Idaho.
So you
It's
like,
crazy.
so there's multiple hospitals. that you-
Yeah, like 7 or 8. Yeah, it's a crazy life.
Okay.
You're at the VA.
I'm at the VA and then another bar, oh, you got Harvard.
Okay.
Yeah.
Yeah, those are my stomping grounds. So, yeah,
Yeah, I didn't get to explore too much around here because it was very rainy yesterday.
and now there's snow
Is there snow?
up in the foothills.
Oh,
Yeah, if you look up, it's covered.
I see. Got it. But yeah, actually, I was in downtown, so the walk up here was quite nice.
Nice.
Didn't realize how much walking within the center there would be.
Yeah.
But found my way.
Yeah, good.
But thank you for.
Yeah, of course.
Um,
Well, so nice to
early
meet you.
morning on the Thursday.
Yeah.
Glad it finally worked. Even here.
Well, here's a picture from my house showing the snow on the night.
Oh, my
So it
goodness.
got down to probably about 5,000 feet.
How far is this from here?
Probably a mile and a half.
Oh, really?
Yeah.
Wow.
Yeah.
Yeah, that's one thing. We had a lot of rain in,
Of course.
just like, the rainy weather in Seattle, but.
Yeah.
We're from here. Coming down here, I was like, it's just colder.
Yeah.
So it's fun.
Yeah.
Yeah.
No, it's, well, thanks for thinking.
Oh, no, thank you for inviting me. It's great to be here.
So I'm a retired cardiologist, but I keep my license up just because it's such a pain in the ass to get it.
Yeah,
So I
absolutely.
need CME.
Got
So
it,
zipping down here and
got it.
get it. Yeah.
Were you ever in the VA system or no?
residency, I did at, University of, New Mexico.
Got it. And they
Spent
had,
time in the VA there.
got it. And then you've been in Boise for your cardiology?
Well, when I finished my residency, it's like, well, now what am I gonna do? I was serving that last. And one of the other guys said, I looked into that. I talked to the Navy recruiter and that sounded like a pretty good deal. You might want to think about that. What do I have to lose? So I went down and I was, I liked what I heard. And so I was actually planning on joining for 2 years and going over to Italy. The base, and then I could, explore Europe during my times off. But partway through that, it became known to me that there was a spot in the cardiology fellowship at Bethesda. And the way that the fellowship there worked is there's 2 fellows for each year.
Okay,
One of them's in the cath lab and one of them's doing everything else.
got it.
So they had made their decisions. And then for some reason, one of them couldn't do it. So instead of taking the number 3 person and putting it in, they were just gonna leave it empty. Quite honestly. They just needed a body. Which is probably what.
Yeah.
Anyway,
So instead of going to Italy.
I went to the test, which
So you're just
Chicago
starting.
cast where I met my
In January, she's already busy.
1.5 years now, so
You guys are hired.
she's a bit of a pain, but so.
If the right person comes. along.
Anyway, so,
Yeah.
and it was a very
So they,
intensive,
the group
cath
here
lab
reached out to me
experience.
when I was a resident in Seattle.
Oh, really?
I think my art.
Of course, they sent
Yeah.
out to.
And then I did
another
my
cast.
PhD and,
Oh, I see.
and then
I don't know if you have any experience with the
as a
military,
general
but they're just
manager.
a little bit
And then I
interesting.
did fellowship.
Anyway,
Came out.
So
I
I
kind
ended
of-
up re-enlisting
Yeah.
on the condition that I could get to, there's
There's
only, at that point, there were all 4 places that had Catholics in the Navy system.
I see.
And so I went to Sanghavi.
What are you gonna do? Oh, cool.
Yeah.
Okay.
Not too bad. And so I was there for 2
Yeah.
years. And that, then it was like, okay, I've been in 6 years.
How are you?
I'm either gonna make this my career or.
Yeah. Yeah.
And, quite honestly, the
We can't
reason that
hear
I
you in
left.
nephrology.
At this point now.
Okay.
I'm ready.
Cardiology division.
That's good.
Sophia was.
What's that French word?
Critical care.
Asshole.
Oh,
He was
Last minute.
5
redirection.
cardiologists left because of
Yeah,
during my time
interesting.
there. It was,
By you? You just like.
It was just-
physically.
and-
Yeah.
and that was still in the Navy hospital.
yeah. In fact, it used to be,
How long? About
the Naval Hospital used to be in, or she had in Balboa Park.
Okay.
Balboa.
Oh,
So you.
And that's where it was. My office there was in, had bridge, so it's all, they took, well, the bars out.
Problem
But
with her,
otherwise
she's
I was
smarter than the rest of us.
yeah.
So we're all having a
And
bit
then
of a
the next
parking.
year,
She has like
we
a whole
moved
social
to
media.
Florida.
My God.
Because they had built a whole brand new
Like, for you
facility.
guys to like 20.
So-
Yeah. I'll have to ask
It
her.
was interesting.
I'm sure she knows it too.
I did not dislike the name, but I just did dislike John.
Yeah, so traveling through Europe, you were just traveling through the US.
You
A lot of things that are, not one
I
person
do, I mean,
did
yeah.
a,
Like skiing
interview.
or snowboard?
Why I was
skiing.
Yeah.
Snowboards,
My son
The
does.
people in
He's an
charge
amazing snowboarder.
Who they are.
Yeah.
just come out.
Yeah.
He's been
I noticed that
snowboarding
too
for
when we
5
had
years now. He switched to skiing. He's 16, but he's gotten really good at
So you don't
snowboarding
have to.
Oh, okay, yeah.
as much as possible.
Oh, sure.
That's like,
Yeah, I
how
mean,
you
this
actually get
year's
all this
been
information.
Yeah.
Not pretty, but
Yeah.
normally we go.
And at
You
the
guys,
time, there was a,
like,
I don't know whether this figure's accurate, but there was a figure rolling around that it
More
cost the
so.
Navy
Yeah.
approximately in the many, many millions of dollars to recruit a cardiologist.
Okay.
Yeah. It's like.
I don't,
Bad.
yeah, hold it up, but
Oh, yeah.
what a great pleasure. And thank you
Okay.
again for
Yeah,
coming
so
out.
it's nice to meet you.
And
So,
they're,
Sanghavi.
Oh, wow.
yes.
You were there 1560
Gotcha.
Hey,
grand.
No, go ahead, go ahead. I'll-
do you know,
I'm not sick.
do you know Sophia Ambruso
I
from
know,
University of Colorado?
but I
She
don't,
just
I don't think
joined
I've
us.
actually met her.
Yeah, we recruited her from University of Colorado. She was at the VA. She was their kind of clinician educator in Denver.
And I ran into her a couple of times, I think at ASN, because she's good friends with like all those like social media people.
She's a freely filtered.
Yeah, so
Moderator.
she'll still do.
She's still doing all that. And then do you know Pedro Teixeira?
Oh, I know him well.
Yeah, so he was a
Sarah
chief here. And Sarah,
Collins.
I kind of had a little small hand in getting her into nephrology.
Oh, good for
And
you.
then he followed her.
Okay. You know,
so-
Pedro's great because he does critical care also.
Yeah.
So I actually was just working, emailing him last week.
Are you gonna talk about 3%?
Everyone wants to.
I know, I'm like,
You
that's such an interesting debate.
Well, it is interesting.
I don't do it yet, but yeah.
I have, so because it's always, it's a topic I never want to speak about. However, I know people do. So after the thank you slide, I have slides.
You have some.
Yeah. So ask your
Interesting.
question and I'll definitely get to it.
Awesome. Hey, how are you?
Hello, Nick.
Good to see you. Yeah.
It's been a while.
Yeah, it's been a while. Good to see you. How are you?
Good, how are you?
Good. Good to see you.
What did you do?
After third year, I was so tired of it. It was like,
After third year.
yeah,
residency.
yeah, it's like, it's a little much. I didn't know how much like long hair, like, yeah, it's a lot. And it's like, oh man, I'm so.
At least it's dry. It's the most you can get.
Also, it's just like, my wife has long hair. With the dog that we got hair.
Oh.
And my wife was like, and I was.
Too much. Someone has to get part of it. We would shave it out.
She's like, okay, whatever.
Yeah, like.
I know for me.
Yeah, no, it's.
Oh, wow, I screwed it down.
When I would shower, I was just like, oh, I have
Yeah.
like a lot of
Very
hair.
disconcerting.
Yeah, yeah. And I'm like, how did I have like, I lose this hair, but then I'm like, I still have so much hair.
It's like this kid was serious. Like, you know, so it's not like so.
Yes.
Okay, yeah.
Now just turn it on.
It's already on. Yeah.
Everyone's
here. Yeah. And it's like, it's.
I'm glad it wasn't too late. I'm getting here.
It's very way back there.
Yeah, so you're like, yeah, it's 7:30.
No, dude, it's like, right. This is
Because nobody can find their way.
one, that. And then the other thing is like, okay, I email people out, so I have a schedule built out, like, in September of last year, right? So, people forget that, so if I leave the schedule, I'm like, hey, we send you your presentation, you're in like biography, just the same thing. Or like 2 days before, right? Yeah, and then like, I emailed them like 2 months out, then like, a month out, I don't know, 3 weeks, blah, 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 and they still can't let me. And then I told you, like, hey, come here like around 7:30, right? And then go like 7:50, 7:59, so I just like set that time, and I'm like, yeah.
Well, for me, it was on the 1%. It's like all over. Yes, it's 29, but I found it.
Gotcha. Wait, so in the Airbnb?
I mean, okay. Sorry, I'm
Yeah.
like on mic here. Where-
Wait, sorry. Oh, I'm listening before Mo interrupts you. Okay. Okay. What, laser?
Okay.
So point at the wall, point at this wall. Okay. And then bring it in. Because a lot of people, they just point up here and then they lose the laser.
Okay.
It's like, yeah, so just point the wall the way up. And then, forward, backward.
7.
Okay,
That's it.
great.
And then if you like can't do anything, it's like not working, all you gotta do, and I'll be right here. You have to just exit out.
Okay.
And then you just go back in again.
Can you bet somebody has?
That's it.
That's first of the mouth. Okay, so you should probably see my mouth right now.
No, they can't see the mouse. No, they can't see that. That's why the laser.
That's what laser, okay.
Yeah.
I'm like,
Cool.
be up there, I'll be whatever.
I will let Mo talk to you.
No. Mo was just telling us we're late.
Oh, okay.
No, I'm different.
Okay. Do I start or do I wait?
No, I can introduce you.
Okay.
Cool. Yeah, I just want people come in. Yeah. Those like your legs. All our teams. Morning, everyone. Today we have Dr. Sanghavi. She's an associate professor at the University of Washington. She is dual board certified in nephrology and critical care medicine, practicing both areas at the Puget Sound VA and Harborview Hospital. She's an educator within the UW School of Medicine, where she directs the renal physiology course, is a core faculty at the UW internal medicine program. And she also brought the Seattle weather with her today. So,
Okay, we don't get down to the 30s, that's you know.
This part,
what?
when you rotated with her.
I did, yes. Yes.
Dr. Sanghavi for like an entire 8
Yes.
months.
I had it back in the top.
To,
Yeah.
so you're like legendary here just from working with Bo for.
Oh, that's very nice. I was actually gonna embarrass him as part of my introduction of myself, but I think we've already done that. But yeah, Mike was a second year resident. That's when I met him. He came to Seattle. He was and sorry, this is embarrassing for you, but he was an excellent resident, was there all the days when all of our residents were kind of coming and going, and he was our continuity for his team. So it was really great to have him. And we love having all your residents. So please tell them if they are willing to deal with the rainy weather to come to Seattle, because we'd love to have them. So thank you for the introduction. Thank you for inviting me. It's great to be here. Even though yesterday was very rainy and cold, this morning was a beautiful walk through downtown and through your campus, and it's been really nice here. So I'll start by saying I do have a couple disclosures. So I am on the medical advisory board for Fresenius Medical Care. We'll not be talking about any of their products today. And then I'll start with some acknowledgements too, because this is a slide that's always often at the end, and I do want to make sure I highlight a couple important people. So I was a resident over at WashU in St. Louis, and Anita Vijayan, who's in that top left, was a nephrologist there. She's now at Intermountain in Salt Lake City, but interested in acute kidney injury and critical care, and continued doing work in that field, and is what got me interested in nephrology. Eric Swenson over on the right is a pulmonologist who I think if you trained at the University of Washington in Seattle, you may know. But I think he's a nephrologist at heart, even though he's a pulmonologist, and he's done lots and lots of research in metabolic acidosis. And much of the research I think was on himself, where he would put himself in hyperbaric chambers and do various experiments. On the bottom row is Bessie Young, who was my former section chief at the VA. She's a nephrologist, was the one who recruited me. And so that was my first foray into nephrology. Prior to that, I actually worked in critical care. And then Yoshio Hall is my current section chief, who has made doing both nephrology and critical care work out for me, which is not off the beaten path of career paths. All right, so those are my acknowledgements. And then today we're going to talk about fluid management in the ICU. And I'm focusing on two different populations. So patients who have septic shock, in which we're trying to fluid resuscitate them, and patients with decompensated heart failure, in which we're trying to take fluid off of them. And there are a lot of similarities between these two in terms of what perfusion targets we're following, how we're assessing volume, and how we're managing. But there are a lot of differences too. So those are the two populations, and this talk is basically divided in half. And so we're starting with a case. So we start with this 62-year-old man who has diabetes, hypertension, BPH, comes to the ER with nausea and dysuria. You see that he is febrile, he's tachycardic, his respiratory rate is slightly increased. That, or someone just wrote 20, because that's a good respiratory rate to have. The blood pressure here is 88/50, giving him a mean arterial pressure of 63. Now he receives the standard 2 liters of lactated ringers. That's what surviving sepsis says, and he clearly has sepsis. And the map comes up a bit. So now we're at 67. They draw their cultures, administer antibiotics, and after that initial workup in the ER, he's admitted to your ICU. And then a few hours later, the nurse calls because she says the urine output's been 30 milliliters per hour for the last 3 hours. This is through an indwelling catheter, and he's still febrile, little tachycardic still, heart rate's 94. Blood pressure is 86/45 now, with a MAP at 59. So I won't have you interact necessarily here, but this looks like a person that you see often in the ICU, get called for often in the ICU. And oftentimes, you know what the nurse wants. The nurse wants you to give fluid, and you have to decide, does this patient need fluid or not? Am I going to help them or harm them? And so there's this dogma in sepsis of giving fluid administration. And the idea is that sepsis is a vasodilatory state. And therefore, if you're pooling blood in your periphery, you're reducing preload to your heart. If you reduce preload, then potentially you're decreasing cardiac output and subsequently organ perfusion. And so this is the assumption we make. The question is, how much fluid is actually needed to overcome this vasodilatory state? Are there other factors involved? Is this patient also volume depleted because they haven't been eating or drinking, because they've been feeling bad, because they have nausea? And so it is really difficult to determine whether increasing preload is actually going to increase organ perfusion. So I think these are the questions we generally ask when we see a patient with septic shock. Is organ perfusion actually impaired? Now, in this patient with a MAP that's below 65, we can say, yeah, at that MAP organ perfusion is perfect, impaired. I would say the urine output suggests insufficient perfusion. It's been 30 mils per hour, which for a standard patient in my ICU is definitely less than 0.5 milliliters per kilogram. It's been going on for 3 hours. So it doesn't quite meet AKI criteria just yet. And often I think you've probably run into this too, where then the nurse says, oh, I turned the patient and 200 mils came out. And so even though we like to think of indwelling catheter as I'm getting perfect information of perfusion of the kidney, it may not be that perfect. And so other markers of perfusion are helpful. Lactate trends, which we do all the time, used to be part of this 4-hour bundle in sepsis. SCVO2, so the central venous oxygenation, can give some information. Capillary refill, which was used a long time ago and is now coming back into practice because of a couple of big clinical trials. And then modeling is something that's in the nursing literature, where looking at patient modeling and assessing that over time can predict, or I shouldn't say predict, but associated with mortality. But again, that just tells us organ perfusion is impaired. What we're really trying to figure out is, will it improve if I give this patient volume? And so when we think about improving cardiac output, preload is just one part of it. Inotropy and chronotropy matter too. We often don't think about chronotropy because heart rates are high when patients are in septic in the ICU. But every now and again, you get a patient with a pacemaker who has sick sinus syndrome, and that pacemaker is set at a rate of 60. And in the past, we've definitely called the companies, asked them to come by and change that rate to 85 or 90, just to give those patients the chronotropy they otherwise would have mounted themselves if they didn't have the pacemaker. And then inotropy. So we know that sepsis causes myocardial stunning in a subset of patients, and sometimes improving perfusion means improving inotropy rather than preload or chronotropy. And then you need to assess the intervention. And I think this is something that we always mean to do and then get busy. And so if I decide that I'm going to give a fluid bolus because of some problem, I want to make sure that fluid bolus actually improves the problem. So if I'm going to use SCVO2 as a marker, I'll check it, give the fluid bolus, recheck it. If you have other measures of cardiac output that you use in your ICU, same thing. Lactate capillary refill, same thing. So I think we've really moved from this idea of volume status to, is my patient volume responsive? And then subsequently, is my patient volume tolerant? So even if I think my patient would respond to a fluid bolus, improve their cardiac output, if they have ARDS and are on FiO2 of 100 and a PEEP of 20, I may still be cautious with that, because I really am at the limit of what I can do with the ventilator at that point. And then the assessment, intervention, reassessment is a thing that the residents hopefully hear me say so much that they're super annoyed with it, because I think that's really important and sometimes is forgotten when we get busy. Okay, and so why can fluid cause harm? Well, this is a really nice picture from the New England Journal of the endothelial glycocalyx. This is when this pointer might, if I can do it. All right, so this is a blood vessel, red blood cells through the blood vessel. You see these little hair-like projections. So these are networked proteins that line the endothelial cell membrane in the blood vessel. And this network of proteins essentially keeps protein within the blood vessel and prevents it from leaking out in the interstitium. But it can be damaged by all the things that get damaged in sepsis. So ischemia, hyperglycemia, inflammation, bacterial lipopolysaccharide, and atrial natriuretic peptide. And when this network gets damaged, what we see is more plasma proteins leaking into the interstitium. So you're actually increasing the oncotic pressure of the interstitium. And so this is why sometimes when we give albumin, that albumin goes straight into the interstitium, and you can actually make things worse by giving albumin in really leaky state. We've seen this a lot in the clinical trials in patients with cirrhosis, where we give insane amounts of albumin and then find that they have high rates of pulmonary edema. All right, this is a very cool study. It's a little bit older. It's from Australia, and in Australia they like to give a lot of albumin. So this was a study where 50 patients who, after the first 6 hours of volume resuscitation, received a fluid bolus, and that fluid bolus was somewhere between 250 to 1 liter. 80% of those fluid boluses were albumin. And what you can see here is that, okay, after the bolus, MAP went up ever so slightly, and it was statistically significant. But so did the norepi requirement. So not sure if that was due to the norepi or due to the fluid bolus itself. What you really notice is that urine output did not improve, SCVO2 did not improve, and lactate did not improve, not statistically significant anyway. And then the PaO2 to FiO2 ratio, basically telling me how well I'm oxygenating, declined with that fluid bolus. And here you can see as cumulative fluid balance increases, that P to F ratio decreases. And so again, just highlighting the harms of giving fluid if the patient doesn't need it. And I'm a nephrologist. I'm supposed to love fluid, right? Or should they tell me? So these are some other studies that just specifically look at survival and mortality. So this is the sepsis occurrence in acutely ill patient study. It was prospective, 3,000 patients, and they found that a positive fluid balance at 72 hours associated with mortality. This one was specifically the next one in patients with acute kidney injury, US study, where a gain of 10% of body weight was associated with increased mortality. And then lastly, we have our ARDSNet trial, where we know our patients with ARDS tend to do poorly with a more positive fluid balance. And here, a negative fluid balance at day 4 associated with lower hospital mortality. Okay, so we know that potentially fluid can be harmful, potentially it can be helpful. How do we figure out when we're giving too much fluid? So this was the CLOVERS trial. It was a huge trial. I know we were a center over at Harborview. Not sure if there's centers that you guys are aware of that participate in this trial, but it's fairly recent. And the goal of this trial was to see, well, maybe after that first initial fluid resuscitation, we should lean more on pressors rather than leaning on additional fluid. And that was really the protocol for the study. So in the restrictive fluid group, they prioritized pressors. In the liberal fluid group, they prioritized more fluid when people had septic shock and worsening hypotension. And you can see that the administered fluid was quite different, 1,200 to 3,400. Vasopressors were higher in the restricted group. But when they looked at their actual outcomes, which was death before discharge, they also looked at renal replacement therapy, mechanical ventilation, ICU days. There was no benefit to a restricted group or a liberal fluid group. So really no differences whatsoever. And so what's telling us is that we don't really have a one size fits all, and we really have to individualize treatment, figure out which subset of patients is going to get better, which subset of patients is going to get worse. And about 50% of patients tend to be fluid responsive in our studies. So it's either way, you could go one way or another. And so you really have to determine which patient's going to benefit or not. And so here are some perfusion targets that we tend to use. Mean arterial pressure, lactate clearance, SCVO2, capillary refill, and we'll go into a lot more detail about each. And then there are these static tools, and I call them static because they give us a snapshot of what's going on, but it doesn't necessarily tell us whether fluid is going to improve things. So that's going to be your history. Patient's been vomiting for 5 days. Your physical, tenting of the skin, dry mucous membranes, the things we like to put in our physical exam when we already know the patient's volume down. Point of care ultrasound, which has become very trendy and in vogue lately. And then right heart catheterization, which is definitely out of vogue, specifically in septic shock patients now. And then these are our dynamic tools. And so these are the ones that are actually supported by the surviving sepsis guidelines. So they admit that the quality of evidence is actually very low. But it's pulse pressure variation with positive intrathoracic pressure and pulse pressure variation with a passive leg raise. And I'll go into those in depth, but just so I know how much depth to go into them, are these things that you guys are using often? Not really? Okay, great. I have slides on them. I just didn't want to be redundant if the things you're already using. All right, so let's start with the central venous oxygenation. I've always liked this because I trained at a time where we used to use early goal-directed therapy, and this was a big pillar of early goal-directed therapy. I see some people nodding. Feel good about that. Thank you for the nod. So what is SpVO2 measuring? It's the oxygen saturation of venous blood returning to the heart, which means that if I put a central line in, which I'm probably going to do because I need to put my patient on pressors, then if I look at the distal tip, which tends to be in the cavoatrial junction, not really the right atrium, but pretty close, then I can say, what is the oxygenation of all the blood in the body that's actually coming back to the heart? And we know that in sepsis, we have mitochondrial dysfunction, meaning that our tissues do not utilize oxygen very well. So they have difficulty in extracting oxygen into the tissues. So the central venous O2, the oxygen coming back, tends to be really high due to this problem with oxygen consumption. And so if I have someone who I know has sepsis, clearly has sepsis, it's not undifferentiated shock, and I find that the SpVO2 is less than 70%, then that indicates that there's actually decreased oxygen delivery. And that decreased oxygen delivery can be from low hemoglobin or decreased cardiac output. So just looking at it in a flow chart, if your SpVO2 is low, then either you have increased oxygen consumption, which can happen with fever, shivering, pain, anxiety, increased work of breathing, or you have decreased oxygen delivery, which again, we know oxygen content is going to be our hemoglobin, our SpO2, all dependent on our cardiac output. So cardiac output times arterial oxygen content. And so again, we're thinking if my SpVO2 is low and my hemoglobin and my SpO2 are normal, then this must be a cardiac output problem. And I come back to this, is it preload, afterload, or contractility? So it's just a way of thinking about if I have a low SpVO2 and sepsis, I give a fluid bolus, then if I'm improving cardiac output, I should expect that my SpVO2 improves. Now, if we use this as a single target, we don't have any mortality benefit. We've not seen that in protocolized early goal-directed therapy in the PROCESS trial, the PROMISE trial, and the ARISE trial, all big multi-center RCTs. But again, just because something does not show that it improves mortality in randomized controlled trials when attached to a very specific protocol, doesn't mean it can't be used in your clinical assessment of patients as long as you're using other information as well. Any questions on the central venous O2? All right, what else can we use? Capillary refill. So seems simple enough. Luckily, there's this group of researchers, mainly in South America, who brought this back. And they conducted this trial called the Andromeda Shock Trial, where they said, we use lactate clearance based on some older data. Do we really need to use lactate clearance, or is capillary refill good enough? I will say I've tried this a lot in my patients at the VA who tend to be older men with peripheral vascular disease, and it doesn't work quite as well. But I still do it. And then I use all my other measures to say, okay, which test was correct, which one wasn't. And unfortunately, the capillary refill in that population doesn't seem to work quite as well as the population they studied. Nevertheless, this was a multi-center randomized control trial, 400 patients. It was kind of cool. They just took a glass slide, pressed pressure on the index finger for 10 seconds, and then released. And then they actually had colorimetric ways of determining when blood returned. Use your eyes as well if you need to. And if the refill time was greater than 3 seconds, that was defined as abnormal. And they found that when they separated patients into lactate clearance versus capillary refill, there's no difference in mortality, renal replacement days, mechanical ventilation days, ICU days, but they did find little less organ injury by SOFA score. So again, I wouldn't say it's necessarily superior, but it's probably equivalent to lactate clearance. And again, if we're using, I think the idea here is that when you're trying to assess a patient, not one test is going to give you an answer, and you're really going to look at everything in conjunction. And so that's one thing you can add to your armamentarium. And then volume status, I think all the residents love to do now, and they have handheld point of care ultrasounds that they run around with. I took out the videos because there's no way I could send this file to Mike with the videos in, but I will tell you that this IVC right here, so you can see liver, IVC, right atrium, did not change at all with respiration. It's incredibly tiny. And this is a picture I took of one of my patients in the ICU. And so sometimes these again are static measures, they're imperfect. However, if it is that tiny, you can probably rest assured that your fluid bolus is going to improve volume status. It's not common that you get such extreme cases. Like the teeny slit-like IVC. Generally, you'll get something between 1 centimeter and 2 centimeters, and that's when you need to do further work to figure out what that means. All right, and so this is one I'll spend a little more time on. It's pulse pressure variation. So in order to use pulse pressure variation, you need to have a patient with an arterial line. Many of our patients, if they're on pressors, if they're sick enough, they're going to have that arterial line anyways. And the original studies with pulse pressure variation were done with patients who are on mechanical ventilation at 8 mils per kg of tidal volume. And the reason that's important is because pulse pressure variation, the way we're going to assess it is with an intervention, and that intervention is positive pressure. And so if with mechanical ventilation at 8 mils per kg of tidal volume, you know you're achieving a higher intrathoracic pressure. So I'll go through this slowly because it is quite confusing. And I'll start here with the blue squares. So when I give higher intrathoracic pressure, I'm increasing transpulmonary pressure. What I'm essentially doing is squeezing the capillaries in the pulmonary vasculature. And so I'm going to actually increase RV afterload and decrease left ventricular preload. Or sorry, I said that wrong. Increase left ventricular preload. So all of those capillaries that are getting squeezed out in the pulmonary circulation, that blood's going to the left atrium and the left ventricle. So preload of the left ventricle is increasing, or left ventricular and diastolic pressure, if that's the way we think about it. So I'm increasing filling of the left ventricle. That's going to increase my pulse pressure, meaning the difference between my systolic pressure and my diastolic pressure, which is a surrogate for stroke volume. So really all I'm trying to do with this is say, if I am preload dependent, then changes in pressure in the intrathoracic space should change my stroke volume. If I'm not preload dependent, I won't see as much variation. So preload dependent meaning you will do better if you get more fluid. But in increasing intrathoracic pressure, I'm also decreasing RV preload because that higher pressure is going to say, well, now blood flow, it's going to be harder to get into my right atrium. And so RV preload will go down. And then when RV stroke volume goes down, it takes a few beats and subsequently left ventricular preload goes down. And so what ends up happening is that at inspiration, you get a maximal stroke volume, so the biggest difference between your systolic and your diastolic pressure. But then a few heartbeats later, at expiration, you get the lowest difference between your systolic and diastolic pressure, so a lower stroke volume. So this is what we mean by pulse pressure variation. Is there variation between the pulse pressure as a person inspires and expires? And if they're preload dependent, we expect to see more pulse pressure variation. If they're not, we expect to see less. And this has been validated as pulse pressure variation changes of 13%, provided that you're using 8 mils per kg of tidal volume. If you're using a lower tidal volume because your patient has ARDS, or because most ICUs have now moved to lower tidal volume ventilation, then you might have a different cutoff because you're not requiring as much or giving as much intrathoracic pressure. So you could say, if I see a variation of 10%, that probably means my patient's preload responsive. Everyone good with that? All right. Yes.
You have to like manually measure this.
Yeah, that's
Automated version.
That's a great question. So on different ICU monitors, so the Philips monitors, the nurses can press a button and actually just have it automatically measure it. What I do sometimes, or at least, and again, this is not the most precise way of doing it, but what I used to do is change the time on the arterial line. And so instead of getting a waveform that looks like this, it scrunches it all together. And so you can see these changes a little bit closer. And you can eyeball it or you can precisely measure it. To be quite honest, I do a lot of eyeball method, but now that we have the Philips monitor to do it automatically, we can actually get the percentage. And I'd say that's the first step, especially if your patient may not be volume tolerant. Because the second step would be, well, I don't really want to give them this fluid bolus if I'm not sure if I can get it off. And that would be your patient who has all uric AKI. And if I keep giving them fluid, then I have to call nephrology or myself and then get the fluid back off. And that's why you're seeing, and you'll see soon, that a lot of the interventions in terms of restrictive fluids actually decrease the number of patients who need renal replacement therapy, which is the opposite of what we used to think, where more fluids help the kidneys. Now we're realizing more fluids just means that now I have to use an artificial method of removing fluid. And so this is the passive leg raise, which has been studied for a very long time now in septic shock and even in ultrafiltration patients who are on continuous renal replacement therapy. And so all you do is you put the patient, initially the patient is sleeping at a 45-degree angle, and then you just put them in Trendelenburg like you're about to do a central line, or sorry, reverse Trendelenburg like you're about to do a central line. And what happens is all of the fluid in the legs and the abdominal compartment, which tends to be about 300 to 500 mils, depending on the size of the patient, is going to now be preloaded for them. And then you would, again, assess your pulse pressure variation at, I'm here, the inspiration and expiration doesn't matter so much because the variation is the variation. And this patient, this one specifically, it's not on mechanical ventilation. Oftentimes they are. You give them preload and you see, does my pulse pressure variation decrease? Well, that's great. And that means that preload is changing giving them extra fluid is changing them from preload dependent to not so preload dependent anymore. It's improving things. And so that's a way you can determine whether that, okay, they got better with the passive leg raise. This is someone I should give a bolus to. And again, you'll still reassess after that bolus because this is not perfect, but it's a nice trial maneuver if you're afraid or concerned about giving fluid to a patient. All right, and then this was a meta-analysis of 50 different studies looking at dynamic measures and static measures of fluid responsiveness. So, and that's one just to highlight how many people are doing this work. And it found that pulse pressure variation and dynamic passive or response to passive leg raise were the ones that had the highest positive predictive value overall and best negative likelihood ratios or predictive value. So overall, those are the two tests out of all tests that perform the best. You can see the static measure they used to compare it to the CVP, which did all right, but not nearly as good as these others. Okay, and then can this actually improve outcomes? I think, that's the biggest question. If I'm going to put all of this work, all of this time, all of these resources into these things, is my patient actually going to be better, or am I just going to feel like I am the very precise intensivist? And there's one trial, it's small, it was 124 patients, but after the initial fluid bolus of 1 to 3 liters, they randomized them to a passive leg raise or usual care. So you could not get a fluid bolus unless the passive leg raise showed that you would improve from a fluid bolus. And when they did this, so this is the protocol that they use. So if you had an increase of 10% in stroke volume change, then you got the fluid bolus. And if you persisted in hypoperfusion, you could repeat it times 1. So this is the way they went. And if you did not improve from the passive leg raise, then you initiated pressors. And so this is similar to what we saw in the Clover's trial, prioritizing pressors versus prioritizing fluid, except now they're using some measure to determine who gets what. And they did find that in the intervention group, you had a lower fluid balance at 72 hours, a lower requirement for renal replacement therapy, and lower requirement for ventilator use. So again, small study, but it was randomized, and we saw benefit with using the passive leg raise rather than just giving fluid. Okay, there's a lot of data here. This one's very recent, which is why I bring it up, but it's just illustrating this point with more patients. So in the Andromeda Shock 2 trial that just came out last year, they used fluid responsiveness in all patients who were randomized to the intervention group rather than usual care. They found 300 milliliters less fluid administered at 24 hours. So I think we're all moving more to more fluid restrictive strategies. So you're not seeing these big changes between 1.5 liters versus 3 liters. But it was still less fluid. And they used a complex composite outcome called win ratios, where they prioritize outcomes like death over outcomes like mechanical ventilation days. But overall, they just edged out with the intervention group at a win ratio of 1.16. Confidence interval just made it so it was statistically significant. So again, this isn't, for some patients, this is probably not going to change anything, but for some patients it will. And again, I think they are a little more restrictive in the South American patient population than we are in the US in giving fluids already. So you just didn't see as much difference in the two groups. Okay. So now I'll switch gears into what fluid do we give? And I can tell you as a nephrologist, I give way more bicarbonate to patients than any of my ICU colleagues. And we have 2 MICU teams at Harborview Hospital. And so I can tell you, not that we're in a bicarbonate shortage, but the pharmacists always know when I'm the attending, because we're definitely giving more IV bicarbonate. So why is this? Well, lots of reasons, but some of it is data driven. And so this is the BICAR ICU 2 trial. There was an initial BICAR ICU 1 trial that was smaller. It was multi-center, open label, randomized control trial of critically ill patients, all of whom who had stage 2 or stage 3 acute kidney injury. And what they were hoping to show was mortality benefit by giving bicarbonate over any other type of fluid. They didn't find that. They didn't find that in the original trial either. And honestly, I wasn't expecting them to find it. But what we did find is that, and actually that's the next page, so I'll get to that. But the intervention was 4.2% bicarbonate. We don't use that in the US. We use push-it amps, which we don't really use, but that's an 8.4%. Or we use a bicarbonate infusion, which tends to be 150 milliequivalents in a liter of water. So that's isotonic fluid, similar to saline. So I can't say for sure that this is generalizable to our patient populations where we don't normally use 4.2%. I also wouldn't advocate that you ask your pharmacy to make up 4.2% specifically for this reason. But just to note that that was something that's different, a different practice from what we do in the US. Primary outcome was 90-day all-cause mortality, and the secondary outcome was kidney replacement therapy. So, okay. Too fast. So again, no change in overall mortality here, but what I think is important is that in terms of receipt of renal replacement therapy, the bicarbonate group required less renal replacement therapy than the control group. And this was an unblinded study, but they had very strict criteria of how they decided to start renal replacement therapy. So it was either hyperkalemia or oliguric AKI and acidosis. And so really all this is telling me is that if I don't want people to have to get renal replacement therapy, which I don't, it is resource intensive, it has an increased risk of infections in some of these trials because of the catheter. It means they're not mobilizing because they're not working with physical therapy, they're attached to a machine, there's clotting, there's anticoagulation, there's a lot of things we'd rather not to use patients if we could. And so if giving bicarbonate up front means I don't have to ultimately use renal replacement therapy, that's a good option. Yeah.
So, I guess my thought process in not using bicarb was that bicarbonate will kind of translate into or be converted into carbon dioxide, and that potentially could increase hypercapnia. Did this study look at whether or not there were higher risks of intubation?
Yeah, so here's the issue there. So their inclusion criteria, their PCO2 is less than 45. So these aren't patients who had hypercarbic respiratory failure. But that's an excellent point, and it is something worth talking about. I will say this trial was specifically looking at patients who had a metabolic acidosis. Most of them had lactates, right down here. It did. Most of the oh yeah, I did. So lactate was about 5.8, bicarbonate was 13, and creatinine was 2.3. These are really patients with metabolic acidosis secondary to AKI and lactic acidosis. But if you do have the patient who has that, plus has hypercarbic respiratory failure, then what do you do? This trial did not address it. I can tell you that about 15% and potentially more, depending on the severity of the AKI, of your bicarbonate will dissociate into water and CO2. Now, if you have a fixed minute ventilation because you're at the limits of what you can do with your ventilator, then yes, that will correspond to an increase in PCO2. It does still raise pH, however. And so I don't have the data here, but there's a few older trials, specifically of patients who are intubated, mechanically ventilated, and they looked at bicarbonate, or they gave bicarbonate of a mg per kg in one and a mill equivalent per kilogram in one study, 2 mill equivalents per kilogram in another, and assessed PCO2 at 5 minutes, 30 minutes, and an hour. And so you do see this initial rise in PCO2. You do see an initial rise in pH as well. But by 30 minutes an hour, that PCO2 has been blown off, even in patients on pretty high mechanical ventilator settings. Now, if you have a patient who's not on mechanical ventilation, then yeah, that's probably enough to get them obtunded, and now you're stuck intubating them. But I think if someone's on mechanical ventilation, you have the plateau pressure is not already 35, maybe you have a little room, it's probably not that. But excellent question. So much that I've definitely done that same deep dive as you were thinking about. All right. And then this is just a couple of slides to show that a lot of the fluid that patients get, I really like that these authors called it fluid creep, comes from other things. So fluid creep was actually medications mostly. So when we sometimes forget that all of these antibiotics we give, the sedation they receive, depressors, heparin, all of that quite amounts to a lot. So this is day 1, day 3. You can see that resuscitation fluids at day 3 counted for very little, which is appropriate because you should not be still resuscitating your patient at day 3. But maintenance and replacement fluids, for whatever reason, were pretty high. And then fluid creep, which is your medications. So if you do want to give bicarbonate, it's probably smart to think about that early rather than later, because otherwise everything else going into these patients is going to give a very high overall daily fluid load. All right, and then this is just another slide illustrating the thing. The only thing I want to mention is that oftentimes when we think about diuretics, we think about I'm removing fluid from the side, from this patient. And if someone is getting 6 liters of INS in a day, you can give diuretic, and maybe then they only have 3 liters in. They're still in a positive fluid balance. And so I think, and the residents say, oh, we're diuresing the patient, therefore they're hypotensive, but they're still net fluid positive. So that doesn't equate. So just something to think about when you're thinking about diuretics. Diuretic does not equal negative fluid balance. It probably equals a less positive fluid balance in most patients with septic shock. And it's safe and okay to give diuretics early on, even if they're hypotensive, because again, you're not putting them in a negative fluid balance. You're just making it so that they're not getting 6 liters positive from all of these, from all of these other things that you weren't even planning on giving them, but ends up coming in fluid.
Do you have a practice or comment on using diuretics when somebody is on vasopressors?
Yeah, so that's a tough question that hasn't been well researched. There's one study in +1 in the journal that looked at vasopressors and diuretics. And I think it really, and it didn't show any harm in giving diuretics in terms of increased vasopressor requirements. But I think the population is really important that you're thinking about there. How are they still fluid positive? Are you trying to aim for net fluid negative? If someone you think is still volume responsive, obviously I'm giving fluid, I'm not taking fluid off. But if there's someone who I think is no longer volume responsive, but has obligate intake of 4 liters a day through medications and nutrition and other things, then I may start diuretics, but it's not to achieve the negative fluid balance. Everyone's interested in that question. It's just the data right now is not great. All right, so that's my summary on septic shock, which is just fluid boluses may not always be helpful, even in patients with oliguria, and can be harmful. Improving perfusion may require more than preload. It might actually require an inotrope or a higher MAP target, and that's what they did in the Andromeda Shock 2 trial. Their protocols were very impressive and worth looking at if you have a chance. Dynamic measures of volume responsiveness include an intervention and an assessment. And then bicarbonate does decrease the need for renal replacement therapy in patients, specifically these patients. So you can't use it in everyone. You can, but you can't say it's evidence-based when you use it with everyone. But in patients with stage 2 and 3 acute kidney injury and a metabolic acidosis. And then those patients who don't have a concurrent respiratory acidosis. And then diuretics may need to be used earlier in the course, depending on the obligate intake. All right, so we're going to switch to a patient that you all know and you've probably seen this week. Someone who has heart failure with reduced ejection fraction, AFib, CAD, comes in with dyspnea. The SpO2 is 86% on room air. The math is actually okay, and nobody ever likes to see that systolic pressure of less than 90. And really the reason the math is okay is because this person's stroke volume or their pulse pressure is actually pretty low. So this is actually probably a patient that's even more concerning that they're maintaining their MAP, because that low systolic and that high MAP really means that their stroke volume is low. On physical exam, they're cool, their JVP is high, they have edema, they have a lactate that's elevated, the creatinine is 1.8, which is not their baseline. And the nurse calls to say, after that 120 milligram dose of IV furosemide, they only have 80 mils per hour of urine output. So this is our cardiogenic shock patient. And so again, we do all the things we do with sepsis, which figure out is organ perfusion impaired. And then in this case, will volume removal improve organ perfusion? And so in the setting of cardiogenic shock, there isn't quite the same specific map or studies on mean arterial pressure that we have in septic shock. So really all of the guidelines that you can find say that we want a perfusing map. And so what is a perfusing map? Nobody knows, meaning that you have to look at markers of perfusion to figure out what is your map goal in cardiogenic shock. And so there are certain things you can use. You can use those same things we used before, SCVO2, lactate trend. Here you can add LFTs because that's a marker of congestion. And again, the one difference I have here is that in sepsis, I said urine output suggests insufficient perfusion because urine output can change in sepsis due to HCN and other things. But in cardiogenic shock, urine output really indicates insufficient perfusion and can be, you can rely on it a lot more than you can rely on it in sepsis. And then here, before we were focusing a lot on preload, now we're focusing more on afterload. And so how do we assess interventions? In addition to the SCV2 and lactate, we're really going to look at CVP, urine output, LFTs, and if you have a PA catheter, cardiac impact. All right, and this is just showing the major guideline societies and what they think about MAP. So no MAP recommendation, no MAP recommendation, no MAP recommendation, maybe more than 65. And then here were patients just with chronic heart failure, so not cardiogenic shock, but they had some MAP goals. What they all do agree on is these renal targets of using urine output, urine output creatinine, and serial monitor urine output and creatinine. So just showing that that really matters a lot more in cardiogenic shock and could be used as a tool much more than mean arterial pressure. All right, so a nice picture illustrating a lot of these same things. Okay. The renal markers, physical exam markers, laboratory markers. And then I'm just going to point out this here, which is hemodynamics, because it's talking about cardiac index, radial arterial pressure, and wedge pressure, and CVO2. And so some of these you can get from a central line, but all these three have to come from a PA catheter. You can also do point of care ultrasound. This is a patient with, this is the hepatic vein, right atrium, and a huge IVC. This is when you put it in end mode and see that that IVC does not change at all with respiration. And an important thing to do is to make sure you're differentiating it from the aorta. I see residents do this all the time where they're like, oh, it's huge, dilated, and then all I do is tilt ever so slightly, and we find the actual IVC. So you're looking at the aorta, and it's easy to, especially when you're coming in with this pretest probability that this IVC is going to be huge and plump. The aorta fits what you're looking for. So good to ensure that's the case, but it has to be interpreted in context. Patients with really bad, severe tricuspid regurgitation, right ventricular dysfunction are going to have large IVCs, and it may not be as helpful. The thing I always think is important in cardiogenic shock, though, is to assess for pericardial effusion, because even if you have someone who has known heart failure, it's a very important thing to rule out. The more important view is this parasternal short axis view, where this is your left ventricle and this right ventricle forms this nice crescent around it. So this is what it should look like, a nice round LV crescent of the RV. This is one of my patients who clearly is not having that crescent at all. The RV is huge. You can kind of see it here. In other views, it's even more apparent. But this LV has a D shape to it. So this interventricular septum, instead of being nice and round, is straight because of the volume and pressure load of the right ventricle. And you may see that in pulmonary hypertension, but then you'll mostly see this D shape in systole. In patients who have RV overload in addition to pulmonary hypertension, this never rounds out. It's just a D shape the entire time. And so if you have someone with RV dysfunction or tricuspid regurgitation, this is much more helpful than the IVC alone. And then, and why do we care so much about congestion? Why do I care so much about congestion? Because I'm a nephrologist. And this is an older study, or this is data taken from an older study of the ESCAPE trial. It was a study of 145 patients who had HFrEF, low cardiac index, high wedge, or high CVP. And they found that when they put PA catheters in them and tried to figure out what correlated with worsening renal function. So this is the worsening renal function group. This is the not worsening renal function group. What you see is that the CVP is higher at baseline and follow-up in the worsening renal function group than the group who didn't develop worsening renal function. But the cardiac index was not really different. If anything, it was higher in the patients who had worsening renal function. And so we've always thought about perfusion. If your heart's not working well, your kidneys are not getting as much blood flow. But this data isn't congruent with that. And there are multiple other studies that have shown the same. That really congestion is a problem. This study came out quite a long time ago, and I think the paradigm has really shifted to the point where the residents I work with now will diary 6 liters off a heart failure patient and then call me because they're like, what happened? The creatinine went up. And so, yes, we do want to decongest. We should still be slightly cautious with that. But yes, diuresis is important. All right, Vexus. I might skip over this because it is complicated. I can tell you I do not do this in routine practice. It is very, very trendy. If any of you are on social media, you can get bombarded with Vexus imaging from a few people who are quite good at it, and have groups that are quite good at it. South America is great at access. I do not know if that is different sizes of people or the ability to have other resources besides point of care ultrasound, but this is pretty hard to do. What you're looking at is congestion. So if someone has an IVC that's greater than 2 centimeters, then you go to these next steps. So I know this patient has big IVC. How can I grade the level of congestion? And so what they do is look at hepatic vein, portal vein, and intrarenal on pulse Doppler. And so you get the vein into view on your point of care ultrasound, and then you click the pulse wave Doppler, and you try to get these nice waveforms. Often, when the patient is breathing, that vein moves up and down. And so you can put a hold on the mechanical ventilator and try to get it. You can ask the patient to hold their breath if they're awake, but they can be difficult. What I find to be a little easier is just to put the color on. And so if normally you should have systolic and diastolic waveforms, you can see down here in grade 3, your systolic waveform actually goes the opposite direction, which means flow is not moving from the hepatic vein to the right atrium, but actually moving from the right atrium to the hepatic vein. If some of you have gotten PE scans on your patients who are volume overloaded, you might see reversal of hepatic flow in the CT read. So that's essentially what this is. And so if I see that my color, if I just use color Doppler, and instead of color going toward the right atrium, which tends to be, if you guys know, blue away, right toward. So blood going away from my probe is going to be blue, blood going toward my probe is going to be red. So if I'm seeing red flow, then that means I'm so congested that I'm backing flow up into the liver. So that can be useful. These are hard. We will skip over them. What about the PA catheter? So again, this is that escape trial with that patient population in which they randomized patients to PA catheter and clinical assessment or clinical assessment alone. And they did not see any difference in clinical outcomes, no matter which way they sliced it. And so PA catheters fell out of favor, even for cardiogenic shock back in 2005. But and I should say, none of these patients were in cardiogenic shock in the study, and yet they fell out of favor. And no difference in renal outcomes in that study. But then what happened? Well, in 2010, we had mechanical circulatory devices, so balloon pumps, Impellas, and that was changing what we could do for patients with cardiogenic shock. And so this is a study looking at North American centers between 2017 and 2021. And what they found is that in patients who had cardiogenic shock, of which there were 2,000, the rate of use of PA catheters across shock admissions went from 8.3% to 73%. So before the time period and after. Because if you are going to use these fancy circulatory devices, you better be sure what your targets are and what you're trying to achieve. So yes, that was the top driver with mechanical support for a cardiogenic shock. And there was, of course, some site-related variation. And when they looked at in-hospital mortality, specifically in these patients with shock, they found that when you had the PA catheter, the mortality was lower than if you didn't. And so when PA catheters fell out of practice, we weren't specifically looking at patients with cardiogenic shock. We didn't have a lot we could do for them. Now PA catheters are coming back into practice because there are things we can do for them. There are a lot of more advanced heart failure therapies, and potentially, again, this is retrospective, but potentially there might be a benefit here. And so now it's important for us to know how to use the PA catheter. I'm going over time, so I will stop and not go over this, but these are values that you normally see, and they're important to be able to interpret. I want to talk briefly about ultrafiltration in decompensated heart failure. So trying to use the dialysis machine to do it works. You can get off the same amount of fluid. So this was a study where they randomized patients to ultrafiltration versus diuretics. They were able to achieve the negative fluid balance that they wanted. However, interestingly, when they used diuretics, pharmacologic therapy, the creatinine declined far more, or sorry, the creatinine change, declined. Now I'm saying this wrong, because I want to say it right. So the mean change from baseline of serum creatinine. Oh, yes, declined. Creatinine declined is a good thing. I should know that. So the creatinine declined with pharmacologic therapy and increased with ultrafiltration, meaning that when we put these patients on dialysis, even though, again, dialysis removes some creatinine, a teeny tiny bit by convection. And again, this wasn't hemodialysis, this was purely ultrafiltration. We found higher creatinine, meaning we're probably causing some ischemia to the kidney in doing ultrafiltration. So in general, diuretics are the way to go when we're trying to get volume off patients. This is a study that shows that if your cystatin C increases, the patient decongest well, you actually have better survival. We used to never have data for thiazide diuretics like metolazone, like at all, and yet people would do it routinely. Now we finally have a little bit of data. So tiny study that shows that when you add metolazone or thiazide, in this case it's hydrochlorothiazide, you get more weight loss, less congestion, and there's a slight rise in creatinine, but we don't have any long-term data whether that persisted. And if it doesn't persist, it probably doesn't matter all that much. I think the better data is actually from the ADVER trial, which was a larger study. Again, patients were not in shock in this study. Median bicarbonate was 26, and they were already on a high dose of home diuretic, of loose diuretic. They had no difference in AKI in 3 months, but better decongestion in these patients. And just skipping over some of these for time. And then I don't know if you guys are doing this often. It's generally one person does it and then tells everyone, and then everyone does it, is checking urine sodiums on patients when you're decongesting them. And I can tell you that at University of Washington, I can't get a urine sodium for patients with hyponatremia, but the urine sodium, it comes with every patient who has heart failure. Maybe the nephrologists are smiling, but this is something that we see often. So this was never really, even though it was part of a lot of review articles and guidelines, it never had really been evaluated. It's just cardiologists tend to be earlier adopters, I think, than nephrologists. But this was a multi-center prospective trial of 400 patients across 29 centers. Again, none with cardiogenic shock, so I don't want to pretend that that's the population we're talking about. But they were looking at standard of care versus protocol. You got more natriuresis in one day by using a protocol, and more cumulative natriuresis over 2 days. This was a super short study. They did it over 2 days. And they said, I'm going to give 2 times my loop diuretic dose. If after 2 hours that spot urine sodium was less than 50 or the urine output's less than 100, I'm going to double the IV diuretic. But if I'm already at 200, I'll add a thiazide. Whereas if not, they just kept going with the same dose. And then day 2, they evaluated the urine output. If it was less than 3 liters, they doubled or added or repeated. So really, they only assessed urine sodium at one period of time, and yet saw a benefit with it. So it doesn't have to be serial urine sodiums. It's really just to make sure that you can get ahead of volume, because you admit them, you're admitting other patients, and often it's the next day before you're assessing, oh, what was the urine output in the last 24 hours? This suggests don't wait 24 hours. Maybe get the urine sodium earlier so you can say, is my diuretic dose effective, and get a higher dose. Okay, so that's my summary of cardiogenic shock patients. The SCVO2 urine output and capillary refill are probably more useful than MAP in that population. If you have AKI, make sure you look at RD function, pericardial fluid. Short-term rise in creatinine is fine, provided you haven't pushed them into ATN. And then your target urine output is 3 liters. And protocol natriuresis is probably effective, easy enough to order a urine sodium. So I don't see any harm in doing so. That's all I have. Sorry it took so long. And if anyone has questions and doesn't need to leave, happy to answer.
Thank you for talking about the glycogens, by the way.
It seems like that's been in medical physiology literature for over 10 years now. And I teach about it, but like every medical student that comes through here through medical school has never heard the glycocalyx before. So my one question is, why is that? Why isn't that part of the medical student education, especially in relation to starting courses? And then number two, there's some research that shows that maybe crystalloids are harmful to the glycocalyx, but albumin is beneficial to the glycocalyx. Do you think that has any practical implication in treating septic shock?
Yeah, so I will say I'm first guilty of not teaching medical students about the glycocalyx because that does come up in our renal physiology course. And I won't go into all of the reasons, but I think at least at the MS1 level, just understanding oncotic pressure, hydrostatic pressure is a lot. Like going into more detail, especially with the abridged curriculum, at least that we have, which is 18 months, doesn't work. So it's really just paring down a lot of the basic science. Unfortunately, 'cause I would love to speak about it, but I was working on materials this week. And so much of what I was doing was taking out things that were too complex to try to emphasize the key points. And this is, now I am on a soapbox, but I think with the use of artificial intelligence and ChatGPT, like it's just going to get worse, unfortunately. To your question about albumin, so crystalloid versus colloid in terms of preserving the integrity of the glycocalyx. I don't know what basic science data for it, but I think in our trials of albumin, we haven't been able to show benefit. In the SAFE trial from 2004 in the New England Journal, we didn't have any benefit with albumin, maybe some harm in traumatic brain injury. In Albios, which was another trial that looked at using albumin to target an albumin greater than 3, so not necessarily as a resuscitative fluid, didn't see a benefit there either. So I think at least in our clinical trials, we're not seeing benefits necessarily with albumin outside of patients who have severe hypoalbuminemia or have cirrhosis. Great question, though.
Do you have any comments about using 3% saline?
Yeah,
in
so
shock
I hate.
patients in the ICU to avoid sort of that fluid overload situation?
Oh, this is different. So I thought it was going to be 3% for decompensated heart failure.
Either.
Okay. So 3% for shock patients in the ICU. I've never done that. I don't know any data for that. I don't understand it, to be quite honest, because you're still getting the same amount of salt. And the way I see it, volume is salt. I know for when you're just visually looking at a patient, you see big fluid versus little fluid, right? And I think that's why we all feel better with small bottle of albumin, large 1 liter bag of saline. But if we're giving 3%, we're giving so much salt. I just can't see how that would be beneficial over it's just a difference in water, which is going to be intracellular. So I've never seen any data on the septic shock. I think the one that still boggles my mind, and that's why let's see, it's here, is when you're using it for diuretic resistance in heart failure, which again, I still don't understand. So there's a guy at Yale named Jeffrey Testani who is the one who started this, and depending on how much you agree with it or not, it sometimes gets into protocols at hospitals. And what they found here, at least in a small study, I think it's like 24 patients, is that when they gave hypertonic saline, they saw the weight change from baseline, and these are patients who are all diuretic resistant, went down precipitously. There's a lot of ideas of how this works. One is that you have so much elevation in renin-angiotensin system when you are diuresing patients with heart failure, and they're chloride depleted, that if you give them a little like hit of sodium chloride, you the macula densa and distal tubule says, okay, I've got fluid, and decreases that renin-angiotensin system a little bit. But then there's some studies from Japan where they actually use very low doses of sodium chloride and still achieve similarly good results. So that hypothesis doesn't really work. Even the people who did these papers have said, we're not really sure why this works or how this works. And so it is really hard for me to use a therapy that I have no understanding of. And in my mind, yeah, you're going to have more natriuresis and more urine output, if I just give you a bunch of salt, that's what the body does. It's going to get rid of it eventually. The weight change is a little harder for me to wrap my head around. And I think in order for me to buy into this, I just need more data with larger number of patients. And then maybe I could forego the biological plausibility. But right now it's not enough. And I will tell you, you're a nephrologist, that even the CONVINCE trial, the hemodiafiltration one, showed a mortality benefit. Still have no idea how it works or why it works. And therefore it's harder sometimes to get over that hurdle for me personally. So I don't use hypertonic saline. It is part of one of our UW Montlake protocols. If you've exhausted every other diuretic, hey, try this. And so sometimes the fellows are like, hey, can we do this? And my answer is, with another attending, you can. I'm not. So it's not wrong. It's just not for me. And I think, yeah, stylistically, I'm allowed to do that. All right. Thank you all. So I actually heard songs about you too. From lots of people. So I don't. You know. Okay. You know Matt Palmer? Yes. Okay. I think he's someone who's talking a lot.
Yeah, well, I retired.
Just sort of crazy.
Oh, wow.
So it's coming down. Ready for it. To you. I would like to give you a tour of the hospital. If I'd like it, we can go give it. Yeah. A budget meeting is, but I can't miss the rest of the week. And so either we'll come to the meeting that you.
That's all this.
That'd be great.
Get stuff
That's cool.
done. Or-
Yeah. Sometimes I would like to put my card in login. Yeah. I do.
HR people and stuff.
You're all good. You're all good. Yeah, yeah.
Yeah. Well, that, when it's tough.
Yeah. HR people are happy with me now.
Good to see you. Yeah.
I just served a 72.
Yeah.
So.
It goes by. Yeah.
We're going to Amsterdam for 3 weeks. Dr. Bo and his ability to get IT up here.
Dude, every day I come here the night before, right? I set it up. And then
Can you like,
the next day.
can you do like a how-to for the next group? Because I have a feeling the next chiefs are gonna start from ground zero and they're
Yeah.
gonna be fumbling